Hello and welcome back. So today I'll be discussing uh, the lymph node compartments in great detail, and then we'll be using them to elaborate on the diagnostic framework that we'd arrived upon in our previous discussion in this series. So starting from where we had left off, this was the diagrammatic representation of the lymph node that I had shown you. So. Uh, this is the actual lymph node, and I had removed the paracortical structures so as to make the diagram more schematic and more representative. Okay, and we have understood that the lymph node has a cortex. Okay, it has a paracortex and it has a middle, and then there's a subcapsular sinus. That is the space in between the tissue within the lymph node. Is what we call the sinuses. So there's a subcapsular sinus. There is a cortical sinus, and then there is a medullary sinus. Okay, and finally, blood vessels, that is arteries and veins, they enter and leave the lymph node over the head. Now, there are afferent lymphatic vessels entering into the lymph node. Okay, and there are efferent vessels that are leaving the lymph node. So, whatever is the lymphatic drainage of the lymph node, lymph from there comes in via this green arrow and it leaves via the arrow. Okay. Now, we have then further subclassified the lymph node based on its structure into four compartments. Now, I just, alluded to this in the previous discussion, but I think we'll elaborate on this a little bit more and understand why exactly these compartments exist. Okay. So, the compartments were, one was the follicular compartment, the second was the sinus, okay, that contains those reticular blue fibers. Third was the paracortex, and the final compartment, that was obviously the mixed compartment. Okay, now what we're going to do is I'm going to introduce these red vessels within the here. So what do these red vessels represent? They represent actually the venous end of the capillaries or within the lymph node. Okay, capillary network within the lymph node, and these are very special vessels because they are what we call the endothelial vessels. Now, the endothelial vessels are different from other vessels in that the endothelium is not squamous, it's not flattened. It is, as you can expect, column. Okay, and these are the endothelial cells that actually interact with circulating lymphocytes and other, inflammatory cells and allow them to enter into a particular tissue. So, um, so how does that affect us in the lymph node is what we need to see. Okay. So now the thing is that within the lymph node, within the paracortex, we have a interesting thing happening. There is production of a particular chemokine. Okay, a chemokine is a protein that signals to usually cells of the immune system to enter into a particular area. So cells, move into tissues based on the gradient of a chemokine, the chemical gradient of a chemokine, provided they express the receptor for that particular chemokine. Okay. Now, the receptor for CCL19 and 21, that is the chemokine that is produced within the paracortex, is actually CCR7. Okay. And the receptor for your CXCL13, which is the chemokine which is produced within the cortex, is CXCR5. Okay. So, for now, we'll have to commit these to memory. And see, it's like learning a language. Initially, when you start something, you have to remember it. Obviously, you need to remember the alphabet. So this is like the alphabet of understanding how the immune system works. So you need to commit this to memory. But I'll try to come about it in such a way that it becomes quite easy and quite intuitive. Okay. So now the question remains: what is producing this CCL19 and 21? So actually, it is produced by a very special type of fibroblast called the fibroblastic reticular cell (FRC) that is present within the paracortex of the lymph node. Now, these cells attract any cell that is expressing the receptor for CCL19 and 21. That is CCR7 is the receptor. So naturally, they end up under homeostatic conditions attracting T cells. Okay, so T cells have a receptor on their surface. This is a T cell. They have a receptor on their surface. This is the CCR7 receptor. So they get attracted towards the paracortex because of CCL19 and 21 production there by this particular cell. It is your fibroblastic reticular cell. Now, conversely, under homeostatic conditions, CXCL13 is secreted by the follicular dendritic cell. So, this is a type of dendritic cell that is present actually within the cortex of the lymph node, and it secretes CXCL13. Okay, and you'll understand just subsequently why this is relevant. So, this attracts any cell that is expressing CXCR5, which is the receptor for CXCL13. Okay, L stands for ligand, R stands for receptor. Okay. So, what are these cells? Under homeostatic conditions, that means when the immune system is not activated, these are the B cells. Okay. So, B cells go towards the cortex and T cells go towards the paracortex. Okay. So, rather reductively, this is understood as, the cortex contains B cells and the paracortex contains T cells. But there is more to this story. So, we'll see what is more to this story. So, basically, after exposure to a particular antigen, um, T cells switch to expression of CXCR5. Okay, and because of that, they get attracted towards the cortex. Okay, now, so you have a T cell, say somewhere here. Okay, lymphatics are draining into the lymph node. They're passing through the sinuses. They're passing in between the cells here. Okay, and because this particular T cell had developed a T cell receptor TCR, okay, that can bind to that particular antigen completely by chance. This T cell gets activated. Now, once it is exposed to its specific antigen, that T cell starts expressing CXCR5. Okay, and that this expression of CXCR5 causes this T cell to actually move towards where CXCL13 is being produced. Okay, that is toward the cortex. Now, once it reaches the cortex, it does something very interesting. It converts to a particular type of T cell called a T follicular helper cell or TFH cell. Okay, and how this happens, we'll get into the details of this, in great detail subsequently. But for now, I'm going to just give you the bare bones details. So now, once it reaches the cortex and it is converted into a T follicular helper cell, it starts to secrete again CCL19 and 21. So now there is a source of CCL19 and 21 within the cortex. Okay, so now CCL19 and 21 is obviously going to attract any cell that expresses CCR7. So you would think that T cells would start getting attracted towards the cortex. But on contrary, what actually happens is once the B cell is exposed to an antigen, okay, so previously it was a T cell getting exposed to an antigen and switching from CCR7 expression to CXCR5 expression. Okay, now B cells at baseline express CXCR5. Once exposed to an antigen, they do the opposite of what a T cell does. So they start expressing CCR7. So now this T cell that has moved into the cortex is going to attack any B cell that is activated or by the same antigen that the T cell was activated by. Okay, so now that T cell and B cell get into a very interesting, choreographed dance, and that is what eventually leads to the production of the germinal center, and that is what I've shown here. Okay, now the details of this, the molecular details are actually very interesting, and they form the basis of all of the specificity of the adaptive immune system. Uh, at least the human lamb of the adaptive immune system rather. So we'll be for now. Let this be a introduction to how this functions. But one thing that we can surmise from this particular introduction is something that is very clear, and that would be that localization of cells within different compartments within the lymph node depends on their expression of the chemokine receptors CCR7 and CXCL13. Sorry, CCR7 and CXCR5. Okay. So in that situation, any cell that is not expressing this is going to actually localize to the correct. It's going to localize to the sinus. Okay. So uh, and this will become very relevant just subsequently because that is the rationale for actually classifying various disorders of the lymph node as per these particular compartments. So, say you have a pathology in which the cells are expressing CCR7, that pathology would predominantly affect the paracortex. Okay, similarly, you have a pathology where the cells are predominantly expressing CXCR5, that pathology would predominantly affect the cortex. Okay, and if the cell is not neither expressing CXCR5 nor CCR7, then that lymph node is that cell is actually going to localize to the sinus. Okay, so there is a mechanistic basis to this kind of compartmentalization, and we use it clinically. So how do we use it clinically? Is what we're going to discuss in this discussion. Okay, so we'll start with a case, Vinet. So this is a case that I have recently, evaluated in my own practice. So this is, however, obviously the details have been changed to, maintain patient anonymity. So this is a 58-year-old lady who has no known prior comorbidities, who has presented with something very interesting. So the patient had presented with one unintentional weight loss. Okay, this was last for the last 6 months. It was gradual in onset. It was persistent. It was progressive. Unintentional weight loss of around 8 kgs. Her baseline weight was around 70 kgs. So this is more than 10% of her baseline weight. And this weight was lost over 6 months. It was associated with some anorexia, that is a decreased appetite. But there was no history of difficulty in swallowing, early satiety, altered bowel habits. Okay. So it was just a decrease in the amount of food that she was taking in that was resulting in the weight loss. So, what was causing this decreased appetite? That we'll see. So, the other complaint that the patient had was a musculoskeletal pain. She had a, for the last 6 months, she had a gradual onset of persistent but episodically worsening lower limb more than upper limb, diffuse dull aching pain. Okay, which was mostly involving the distal more than the proximal parts of the lower limb, but it was in the upper limb, at least as per her, more generalized. The pain was associated with a nocturnal worsening and with partial response, but only partial response to NSAIDs. Okay. Now, so from our discussion on the an approach to MSK pain, you would recall that this would then classify as possibly an extra-articular location or the origin of the pain. An extra-articular can be a lot of things. It could be muscle, it could be fascia, it could be subcutaneous tissue, it could be periosteum. Okay, and strictly speaking, based on this history, I really cannot differentiate. What I can say is it is not due to claudication, that is neurogenic or vascular claudication, because there is no positional change and there is no worsening with activity. Okay. However, I cannot go further than that. So it could be any of these things. Okay. So uh, there was no history of vascular or neurogenic claudication. There was no significant early morning stiffness, swelling, or redness involving these areas. On examination, she had a cervical lymph node. This was the only potentially diagnostic clue that she had. Okay, which was 1 into 1 centimeter in level 5 lymph node on the left side, and it was not really tender. It was very mildly tender. It was soft in consistency and not really tethered to overlying skin or underlying tissue. Okay, there was no other lymphadenopathy anywhere, no goiter, no other neck swellings. Okay. Now the question arises, this is significant lymphadenopathy, or at least almost significant lymphadenopathy, and this is the only clue I have to go by, essentially. So, what do I do? So, naturally, we would go for, because it is in an accessible site, excision biopsy of the lymph node. So, my final impression prior to taking the excision biopsy was a persistent, poorly localized, distal more than proximal, lower limb, dominant extra-articular pain with significant unintentional weight loss with localized left cervical lymphadenopathy and elevated inflammatory markers such as CRP. The patient had already been evaluated by medicine, by internal medicine, and they had sent an ANA by FA, which was 1 plus speckled with an N titer of 1 is to 80, which is essentially not really significant. And they had also sent extractable nuclear antigen profile, and that was also negative by line immunoassay. So this is where we were at. And see, in such a case, the lymph node can only tell you something if you know what you're looking for. Okay. So, in the course of this discussion, I'm going to try to elucidate that and I'm going to try to make it clear as to how that helps you, fine tune the diagnostic framework that we had arrived upon previously. So, now moving on, what are the topics that I'm going to be covering in this discussion? So, I'll start with uh, we'll try to understand how different mechanisms of lymphadenopathy produce different patterns of lymph nodal tissue enlargement or hyperplasia. Okay, hyperplasia here is used in a clinical sense. Okay, if I give you could allow me that, you know, leeway. So, what do I mean by that? I mean that it's not necessarily an increase in cell numbers. Okay, so it could just be due to cell infiltration also. However, moving on. So the second thing we'll do is we'll look at the different patterns. First pattern we'll look at it will be the follicular pattern. The follicular pattern will consist of three benign abnormal patterns, that is follicular hyperplasia, mantle zone hyperplasia, and progressive transformation of the germinal center. It's not the mantle zone, this is of the germinal center. Okay, germinal center. Second, we'll discuss regarding the sinus pattern, and with the cells that I've just discussed, only histiocytes essentially do not express CCR7 and CXCR5, so they end up, not being able to get into the paracortex and the cortex, so they sit in the sinus. So we'll be talking about R group histiocytosis, and we'll discuss what this means. R stands for rosy-Duchenne disease, and this is what we'll be discussing in detail. Then we'll go to the paracortical pattern. We'll try to understand why the paracortex is affected in sarcoid lymphadenitis, and then we'll try to talk about, try to differentiate it from SLE lymphadenitis and something that looks morphologically very similar and is pathophysiologically in a similar spectrum, that is Kikuchi Fujimoto disease. Then I'll finally end with a discussion on the mixed pattern, and obviously infections, can cause a mixed pattern because they cause multiple cells to get activated. So, in particular, we'll be talking about the classic triad of toxoplasmosis. And finally, we'll update our diagnostic framework, and it'll be the end of our discussion. So, starting with benign hyperplasia or infiltration, as I've just described, in a follicle pattern. So, naturally, this would mean that the cells that are here in the follicles are um, are expressing CXCR5. I hope that is clear. Um, so follicular would mean that this is the area of the lymph node affected. So there are three entities that are there. So three benign entities that might cause this. One is reactive hyperplasia. The second is mantle zone hyperplasia. The third is progressive transformation of the germinal center. Now, I've also included Castleman's disease here, but Castleman's disease is not a benign entity. It's actually a neoplastic entity. The reason I've included it here is actually to compare it to IgG4 related disease. Okay, and we'll get to that in just a bit. So, what do you see here? This is obviously a high power view of the follicle within the cortex of a lymph node. So, I've labeled these the parts of the germinal center here, the follicle, as A, B, and C. Okay, and this represents what we call follicular hyperplasia and mantle zone hyperplasia. So here E stands for the expanded mantle. That is the mantle zone, the bluish cells here. They are much thicker than we would normally expect. So this is what we call mantle zone hyperplasia. A normal finding. The B is actually the dark zone of the germinal center. And what the light zone and the dark zone represent, we'll get to at a later date. But suffice to say, in a fully formed germinal center, there is a dark zone and there is a light zone. Okay. So the supposed darkening is due to the high NC ratio of the cells within the dark zone, and the lower NC ratio of the cells in the light zone give it the light color. Okay. So this is an example of normal follicular hyperplasia and mantle zone hyperplasia. This happens when there is any type of adaptive immune activation. Now, there is another entity called the progressive transformation of the germinal center. This is also a benign normal response to, um, hyperplasia of in a follicular pattern. So there are three described stages, and they're quite intuitive. So we'll just get into it directly. Stage 1, 2, and 3, as I've labeled in the diagram. So stage 1 actually consists of multifocal ingress of small lymphocytes into the germinal center. So as you can see here, these mantle zone cells, which are so dark blue in color, they seem to be trying to enter into the germinal center. But I can still somewhat sketch out an actual germinal center. So there is a germinal center, but there are multiple areas in which the mantle zone is actually trying to enter into the germinal center. Now, in the second diagram, what you see is there is a clear loss of the demarcation between what is the mantle zone and what is the germinal center. So there is an island of germinal center here. There is an island of germinal center here. There is another island here, and there are some a few smaller islands here. There is some here. So it's not very clear. The demarcation is completely lost. Finally, we have such a big, a huge expansion of the mantle zone and such a reduction of the germinal center that you can barely see the germinal center. So the germinal center is completely replaced with small lymphocytes of the mantle. Okay, so these are actually the three stages of progressive transformation of the germinal center, and this is a normal thing. It's a completely normal finding. Okay, it correlates with the resolution of an adaptive immune response. Now, in chronic infections, and naturally as well as in your chronic autoimmune rheumatic disorders, with a certain caveat, that is without significant type 1 interferon production and without significant granuloma formation. Okay, these are the two caveats that I've added. You'll understand just now why I've added those caveats. So actually this essentially just leaves us with rheumatoid arthritis. What you find is that we have significant very florid follicular hyperplasia. Um, Except that the degree of follicular hyperplasia is extremely, profound. It is very, very significant. And these follicles assume these very bizarre shapes. So, see, as you can see, it's almost a geographic pattern of a follicle. The follicle is so expanded that it looks like its borders look like that of a state or a country. Okay, so this is actually a syphilitic uh, lymph node. What was, traditionally called a lewitic lymph node. Now, we don't call it that. I just call it a syphilitic node. Uh, so there is very significant florid hyperplasia in a bizarre geographic pattern. Okay. Also, into this side, you can notice that there is a little bit of thickening of the capsule. Normally, the capsule is just a single line, it's not so prominent. You can see multiple parallel lines forming a thickened capsule. So, actually, that thickening is what gives its rubbery, quote unquote, consistency. And that is why we call the lymph nodes in syphilis choppy. But you could get similar changes in other conditions, particularly rheumatoid arthritis as well. Okay. So, now these were the causes of in situ cellular proliferation due to excess immune activation. Okay, that we were discussed in our first discussion in this series. Um, and naturally, these are disorders in which there is immune activation, prominent adaptive immune activation, and therefore, except for the disorders that I have shaded out, that is Rosai-Dorfman disease and Kikuchi-Fujimoto disease. These are entities which all are likely to present with this kind of florid follicular hyperplasia. Okay, so it wouldn't be very useful to do a lymph node biopsy in these conditions. Okay, so just as a thought experiment, you would expect some follicular hyperplasia in SLE and sarcoidosis, but see, SLE is a type 1 interferonopathy, and sarcoidosis has prominent Th1 polarization with granuloma formation. So, else would you expect? This is a thought experiment that I've given to you. We'll be getting to this just subsequently. You can pause and think about it. Similarly, lymphadenopathy and splenomegaly as a part of infection would also cause significant florid hyperplasia. Although, as we've just seen, immune activation in infections can activate multiple cell types. So, because of that, there could be mixed or it could involve multiple compartments within the lymph node. So, what we'll do is we'll just put a pin in this for now and we'll get back to this later. Okay. So, suffice to say, all entities that had included under um, you know excess immune activation resulting in lymph node enlargement would be expected to have follicular hyperplasia unless they have very significant type 1 interferon production or they have excessive granuloma formation or specifically they are either Castleman's disease or Rosai-Dorfman disease. So let's just talk about Castleman's disease. Customers disease is not benign entity, as I've just alluded to, but I am going to use it as an intro to a benign entity, which is very close to my general, evaluation of patients. That is IgG4 disease. So the diagram that I've just shown, or the pictomicrogram that I've just shown, shows a very small uh, germinal cell surrounded by a relatively thick mantle zone. Although I've not shown you the exact mantle zone. Now, actually, this is not even relatively small germinal center. This is actually two very small germinal centers. Okay, so these are small germinal centers, called atritic germinal centers, present within atritic follicles. Now, so like I said, there are two germinal centers surrounded by a very expanded mantle zone, and this does resemble, if you just recall, the stage three of your progressive transformation of the lymph node. But there is something more. In this next section, what we see is in a similar athletic follicle, there is a expansion of these this kind of myelinized blood vessel. How do I know it is a blood vessel? Because of the shape of the endothelial cells there. Sometimes you're able to see an RBC within the lumen as well. So this is actually a feeding blood vessel surrounded by you know, layers of an athletic germinal center. And this is what we call lollipop sign, rather imaginatively. Okay. Now, on the other hand, on the left side, I have shown you an extensive infiltrate of the lymph node. And so essentially, you cannot dis- discern the underlying architecture of the node, which sheets of cells which are elongated. They're like this. They have a nucleus that is a little eccentric, that is, it is away from the center of the node of the cell. And there is actually, if you look very carefully, although I'm not very sure if it will be very clear, but you can see it in this cell at least. There is a perinuclear sparing. And that perinucleus pairing is the giveaway point that this patient actually has, or this lymph node is actually replaced with plasma cells. Um, these are plasma cells. And how do I know they are plasma cells? Because this, what I've done now is I've done the IHC for CD20. Now, CD20 is expressed by all B cells except for the first B cell in production in the production line, that is your pro B cell, and for the last B cell derivative, that is your plasma cell. So, as you can see, all these cells here are not showing uptake of the uh, the marker for CD20, and so these are not normal B cells. You do find some here, okay, and these are present inside the germinal center that was paired. But in the interfollicular, or the region between the follicles, you have a diffuse infiltration with these CD20 negative cells, which morphologically resemble plasma cells and therefore are plasma cells. Okay. Now, this is therefore the hyaline vascular variant. The first one, this is the hyaline vascular variant of Castleman's disease. And on the left side, we've got the plasma cell variant of Castleman's disease. Okay. Now, with having gotten our bearings regarding Castleman's disease, uh, one thing that is very clear is that there is actually flatted vascular proliferation in Castleman's disease, and the reason for this is there is increased production of interleukin 6 and secondarily vascular endothelial growth factor, resulting in neovascularization. And we'll be getting to this subsequently in a deep, in depth at a later point. But for now, I think this would suffice. Okay. Now, mm, Castleman's disease clinically is three types. It can be multicentric Castleman's disease, that is HHV8 negative. It could be multicentric Castleman's disease, that is HHV8 positive. Here, HHV8 stands for human herpes virus 8. Okay. And it could be unicentric, that is clinically there is only one single lesion. Now, the pathophysiological spectrum, that is of the plasma cell variant, uh, you find it predominantly in HHV8 negative multicentric Castleman's disease, which is actually the true neoplasm. We'll get to this in the next discussion in this series. Uh, Myelin macular variants are much more common in lymph node biopsies from unicentric carcinomas disease. It can happen with HHV8 positive multicentric carcinomas. They are uncommon with HHV8 negative multicentric carcinomas. Mixed, that is, a combination of the two, can occur with HHV8 multicentric carcinomas as well as HHV8 positive multicentric carcinomas disease. Okay. So, why talk about such great detail? Because I want to compare this to IgG4 related disease, which is it's a disorder of immune resolution. So, it's not a neoplastic disorder. Okay. So, it produces actually multiple patterns. It produces 7 separate patterns in the lymph node. And two of these, the paracortical and the sinus pattern, we will be just getting to. But I wanted to highlight the follicular nature of the lesions before that. So there can be follicular hyperplasia, there can be progressive transformation of the germinal center, there can be plasma cell variant of Carson's disease, like expansion of the interfollicular cortex and the pericortex. Then you can have paracortical or interfollicular expansion of plasma cells or immunoblasts. Immunoblasts are just activated T or B cells. Okay, I'm going to discuss the morphology subsequently. It can be infectious mononucleosis where there are multiple immunoblasts. Okay, atypical looking lymphocytes. Then it can be limbal or sinus pattern disease, that is Rosai-Dorfman-like disease. That is good to get. Finally, it can look like something called formally actually called an inflammatory pseudotumor like pathology. But we don't use the term pseudotumor anymore. So what we call it is we call it inflammatory myofibroblastic tumor. Okay. Inflammatory pseudotumor was actually a umbrella term that was used previously for multiple lesions in which there were large cells infiltrating the tissue and surrounded by varied assortment of inflammatory cells. So all of these entities are termed IgG4, but that is only if they show either one of these two things. That is, there is an IgG4 by IgG ratio of more than 50%. That is, more than 50% of the plasma cells in this or in the tissue express IgG4, not the other IgG subtypes. Or you have clusters of more than 50 IgG4 positive plasma cells. Now, it's rare, and often these latter, that is, the presence of clusters of more than 50 IgG4 positive plasma cells in a high power field, is the finding that you do get that results in diagnosis. Okay. So, okay. Now, IgG4 IgG, although it is the defining feature of these biopsies, can be false positive in multiple cases, and in that case, essentially, if you've written a diagnosis on a piece of paper, you have to tear it apart, so that this diagnosis has to be torn apart. Now, therefore, IgG4 can be notoriously difficult to diagnose in lymph node biopsies. So, uh, my intention here is actually to appraise you regarding the possible causes of this kind of an IgG4, you know, cell variant, IgG4 expressing plasma cell infiltration into the lymph node, and to be wary of the fact that IgG4 should not ideally be diagnosed just based on a histopath of the lymph node. So, TORN obviously is a mnemonic that I use, and it stands for TORN, T for tuberculosis. Okay, or any other chronic infection, including syphilis. O stands for oral cavity lesions. These are lesions that have been caused by a ill-fitting denture that is causing recurrent mucosal damage. R stands for Rosai-Dorfman disease. Okay. The Rosai-Dorfman disease is an entity in which you get large histiocytes as well as plasma cells. And there are very limited entities that cause this. So the next video in this series, or the next discussion in this series, will be dedicated to those entities, and I look forward to discussing those with you. N stands for nodular lymphocyte predominant Hodgkin's, and we'll be discussing the histopath of this entity. It's not really a Hodgkin's lymphoma; it's actually a B cell. It's a normal B cell lymphoma, but because of the presence of a particular histopathological appearance, it is grouped under Hodgkin's. So that's why the codes. Okay. Now, for now, what I would want you to know is that there is a perifollicular granuloma variant of IgG4 related disease, and there is also a perifollicular granuloma variant of nodular lymphocyte predominant Hodgkin's, and they can closely resemble each other. So they can then only be differentiated based on immunohistochemistry and cytogenetics. So this is something that I would like you to recall for now, and then we'll get to why this happens at a later date in our discussion on Hodgkin's lymphoma and then subsequently histopathology of these lesions. Now, coming to the second pattern, that is your benign hyperplasia or infiltration in a sinus pattern. So, naturally, these would be cells that do not express CCR7 or CXCR5. This is the sinus. This is the, we would call it the subcapsular sinus. And this is the also the subcapsular sinus. Now, um, this could include just some benign histiocytes coming into the sinus from the drainage, you know, basin of the lymph node. It can also be histiocytosis like Rosai-Hoffman disease, and we'll just get to it. But this is called R group histiocytosis. It could be malignant histiocytosis, also called M group histiocytosis. And see, Rosai-Hoffman disease is actually called sinus histiocytosis with massive lymphadenopathy. So the name is actually very telling for once. However, if you review the clinical presentation of Rosai-Hoffman disease, DD, Rosai-Hoffman disease actually present with subcutaneous lesions. So this is something that you must keep in mind. Even though I have discussed this under an approach to lymphadenopathy and specifically in the histopathological assessment section, the more common presentation is actually as a subcutaneous nodule with or without dermal infiltration. Now, histiocytosis are at a very basic level can be differentiated based on their immunohistochemistry. Because all of them show these large cells with relatively small nuclei that have infiltrated into the sinuses. So the IHC markers for normal sinus histiocytosis are CD68 and everything else negative. So S100 negative, CD1A, which is Langerhans negative, and there are no other cells infiltrating other than for histiocytes. So this is a benign thing. Whereas in Rosette Hoffman, what you get is you have CD68 positive, you have S100 positive, but CD1A negative. Okay, and along with that, as I just discussed, there will be plasma cells that come in. We'll get to why this happens in the next discussion. In Langerhans cell histiocytosis, CD68 may not be positive. Okay, this 100 is positive, and then it's Langerhans cell because it expresses Langerhans. So CD1A is positive, and along with this, you can get eosinophils. So, orthopedics typically like to call it eosinophil granuloma. Um, some histopathologists also do the same. I am predisposed not to use that terminology, but it's up to you. Um, we divide histiocytosis is of now into the following categories. We have a classification system. So we have these L group histiocytosis, L standing for Langerhans cells, and then other histiocytosis, which includes the C group. C stands for cutaneous hair. R group, also Beckman. Uh, please note that often more commonly is cutaneous. M is another, it is malignant histiocytosis, and H stands for hemophagocytic lymphohistiocytosis. In my personal opinion, this appears like a mismatch of various disorders under the general histiocytosis just because there is histiocytes in the biopsy. Um, However, um, this is the established classification as of now. Now, what I like about this is that the subgroups themselves are actually pretty homogeneous, and that helps me understand them pathophysiologically. So, Langerhans cell group histiocytosis is further divided into Langerhans cell histiocytosis, which contains Langerhans cells, is therefore CD1A positive, CD207 positive, may be negative for CD68, and is negative for CD163. Erdheim Chester disease, which is always CD68 positive and 163 positive, but negative for CD1A and 207. Then we can have intermediate cell histiocytosis, it is in between, and we can have a mixed LCH, that is Langerhans cell histiocytosis, and Adam-Chester disease variant. So, in this series, these are the entities that I'll be discussing. It would be R group histiocytosis and M group histiocytosis. Um, R group histiocytosis will be discussed in the next discussion in this series, that is part 1.2, this being part 1.1. And M group histiocytosis will be discussed a little bit later in part 3.1, which is actually histology or histopathology in the diagnosis of lymphomas, specifically presenting with a histopamorphological finding of sheets and red cells. Okay. Now, L group histiocytosis will be discussed under an upcoming series, that is approach to prolonged fever. And C group will be discussed in the ongoing series on approach to rice. H group will be discussed under approach to an alteration in peripheral blood counts. So, see, my general clinical approach to these disorders leaves me uh, in this rather precarious position where I have to discuss these entities separately. But as I've just said, these individual entities are actually relatively homogeneous. And reason when I get to these entities under these different headings, I will review this classification again. So now what do you see here? What you see is actually a lymph node section. So in the lymph node, there are these relatively large cells. And what large cells are cells that have nuclei that are larger than actually two lymphocytes. And we'll get to that at a later stage, and I'll define it formally then. However, there are some few cells, there are some syncytia that are there, uh, and there are these large cells. Now, to understand these large cells, I've drawn these schematics. Okay. On the right of your screen, that is this diagram, we have something interesting. We have the Rosai-Dorfman disease histiocyte. Now, why is it called a Rosai-Dorfman histiocyte? Because of its morphology. And this is very important. It is because of morphology, it is not because of immunohistochemistry. Um, on the left, we have Langerhans cells, which is again described based on the histological morphology, the histomorphology. So, what are the differences between these two types of histiocytes? So in case of RDD histiocytes, we have a round with oval nucleus with a fine chromatin and a few nuclei scattered in. In case of Langerhans cells, the nucleus is round to oval but has a fine chromatin with a folded nuclear appearance. So this, as you can see, there is a nuclear fold present in the nucleus. Additionally, there is abundant but pale grayish cytoplasm in case of the RDD histiocyte. And there is abundant deeply eosinophilic is cytoplasm in case of the Langerhans cell. It is this nuclear morphology that is distinctive. Okay, and it is not what I'm going to describe subsequently. That is the presence of these two cells within the cytoplasm, which is called emperipolysis. That is diagnostic of RDD histiocytes. Although, if you read a textbook on this, you may consider that to be the pathognomic finding, but that is not the pathognomic finding. It is the nuclear morphology and the cytoplasmic morphology that are far more important. Emperipolysis can be a normal finding. Now, what is emperipolysis? Emperipolysis is actually it is the passage of intact cells, usually lymphocytes, through the cytoplasm of another cell, and this is because of the expression of cell adhesion molecules by both cells, and at no point is the cellular integrity of either cell breached. So this is not phagocytosis. Okay. So now you'll be able to differentiate these two types of histiocytes. So getting rid of these two diagrams, getting back to our actual histopath slide, what do we see? So I would like you to concentrate on this cell. This cell has a very like nucleus. It's fine chromatic, and there are some specks of nuclei. The cytoplasm is very abundant, bit pale, not eosinophilic, and it contains two lymphocytes here and one lymphocyte here, relatively intact. So this would be IBD histiocyte. So what do we have at our hands? What do we have? Roside enlargement disease based on histological morphology or histomorphology. Again, not based on immunohistochemistry, not based on the presence of empiricolysis, but rather the nuclear morphology and the cytoplasmic morphology of the cell. Moving to the third category of infiltration, that is benign hyperplasia or infiltration in paracortical pattern. So again, paracortex is this region and this region, and it consists of something called dermatopathic lymphadenitis, which is just lymph node enlargement in any range of dermatological conditions. Um, then what I'm more interested in, that is SLE lymphadenitis, Kikuchi Fujimoto disease, and granulomatous disorders, including sarcoidosis. So now, if you notice, the latter three disorders are basically either one due to excess type 1 interferon production, that is an antiviral immune response. So that would include your SLE lymphadenitis and Kikuchi Fujimoto disease, or it is due to granulomatous infiltration that happens, the archetype of which is sarcoidosis. So let's see what happens. And before we go into that, I'll just write a few words on Kikuchi Fujimoto, just to give you ground view. So this is actually a disease in which the paracortex of the lymph node shows, oddly shaped eosinophilic areas, which are composed basically of plasmacytoid dendritic cells, which is a type of dendritic cell which is prominently activated by viral molecular proteins. So it expresses three TLRs 3, 7, and 9, and these are TLRs like receptors that bind to nucleic acid fragments and therefore detect viral infection predominantly. It also contains karyorectic debris. Now, karyorectic, the word arises from two separate words. Karyo implying the nucleus, and rectic means destroyed. Okay, so destruction of the nucleus would produce nuclear colored debris. So that would be a intensely basophilic debris. Okay, and this often surrounds an area of confluent necrosis. The reason for necrosis here is actually the type of interferon production and not due to loss of vascular supply or due to um, per se, you know, uh, complement mediated necrosis. Now, histocytes here are positive to CD68 and 123, making them plasmacytoid dendritic cells. However, they also show aberrant expression of an odd thing for a plasmacytoid dendritic cell to express, that is myeloperoxidase, which is normally expressed by normal histiocytes and neutrophils. Now, again, there may be a central area of confluent necrosis, but unlike SLE lymphadenitis, these areas do not stain for C4D, which is a final product of complement activation, just if any complement activation, um, and therefore indicating that this is not complement mediated necrosis, unlike in SLE. Now, basophilic areas between the eosinophilic areas are composed of immunoblasts. Now, if you remember, immunoblasts are any activated T or B cell. But these immunoblasts are not T cell phenotypes, so they express the T cell marker, pan T cell marker CD3, and the pan leukocyte marker CD45. Okay. Now, this is different in contrast to its morphological differentials. I'm just putting it out there for now, and we'll get to this when we discuss these diseases in detail in subsequent discussions in this series. But this includes DLBCL with diffuse large B cell lymphoma, which is a B cell, mature B cell lymphoma, and therefore would express B cell markers. And it includes your classical Hodgkin's lymphoma, which has a very specific type of large cell that has a very specific immunohistochemical profile. So this large cell expresses CD30 always. Usually, with, you know, almost always expression of pathway, and usually also expresses CD15. It does not express the common leukocyte marker CD15. It is negative for other B and T cell markers. Okay. So now before we jump into the histology of this, let's compare these three entities, that is sarcoidosis, SLE, and Kikuchi Fujimoto disease, in terms of the clinical presentation. So, because before we interpret any investigation, we need to evaluate the greatest probability. Okay. So, what is the prevalence of lymphadenopathy? What is the site of the said lymphadenopathy in these three lesions? Um, what are the other clinical findings? For example, what are the constitutional features such as fever, unintentional weight loss, and elevated inflammatory markers as well as hepatosplenomegaly? And what is the prevalence of joint pain, leukopenia, atypical lymphocytes, and EFT patients? So these are the things that you're going to talk about. Now, both sarcoidosis and SLE obviously are systemic lymphatic diseases. So they are commonly have joint pain and rash. Um, in sarcoidosis, lymphadenopathy is relatively common. It's not, I wouldn't call it uncommon. So it is present in 10 to 40% of cases. In case of SLE, it is very uncommon. Significant lymphadenopathy is typically described in less than 5% of cases. Kikuchi Fujimoto is defined by the presence of lymphadenopathy. So it is present in 80 to 100% of cases. The site of lymphadenopathy in sarcoidosis is typically generalized, but characteristically hilar mediastinum. In SLE, it is cervical, bilateral, more than unilateral. Okay, but it can be unilateral and it can also be generalized. But that is uncommon. In Kikuchi Fujimoto, it is never generalized or very rarely generalized, but it is cervical and it is usually unilateral and cervical, typically in the posterior cervical nodes. And these nodes are typically discrete, that is separated from one another. They are linear over underlying tissue and overlying tissue, and less than 2 centimeters in area. So, could this could the patient that I've discussed earlier be Kikuchi Fujimoto? Maybe. In terms of presentation, constitutional features are not part of sarcoidosis because sarcoidosis is a excessive Th1 polarized granulomatous response, and constitutional features happen due to innate immune activation, which is something that is not happening in sarcoidosis. In SLE, constitutional features do happen during flares, which are otherwise uncommon. Typically, unintentional weight loss and fever. Okay, unintentional weight loss as well as elevation in ESA is something that is really concerning in any patient with SLE. Now, Kikuchi Fujimoto, 50% of patients have a fever like symptom. And actually, fever is present in 80 to 50% cases. Unintentional weight loss is present in a not so insignificant number. It is 1 in 10 patients, 10% of cases. ESR is present in 50 to 50%, 70% of cases. And hepatosplenomegaly is uncommon. It's present only in 3% of cases. So, as you can see, because of my prior understanding of these disorders, I was thinking of Kikuchi Fujimoto in this patient. Now, joint pains, this patient did not have joint pain, she had extraarticular manifestation, she had extraarticular musculoskeletal pain. Joint pain is not common with Kikuchi. Okay, it happens in only 7% of cases. And rash is present in 5 to 20% of cases, the patient did not have rash. So, as of now, she fits quite well into our understanding of Kikuchi. Leukopenia happens in sarcoidosis, and it's actually the most common hematological malignancy you see in hematological abnormality you see in sarcoidosis because of uses of lymphocytes. The lymphocytes are being used up in the formation of these granulomas, and when these lymphocytes are not essentially activated, so there are no atypical lymphocytes. Um, Granulomatous infiltration into the portal triad results in an elevation of ALP, resulting in a cholestatic pattern or liver enzyme elevation. And this is when present, can increase the platelet probability of sarcoidosis. In case of SLE, leukopenia happens due to type 1 interferon. And again, these are not particularly activated lymphocytes, so it would be rare to see atypical lymphocytes. That is, lymphocytes that have atypical nuclear features and worry about malignancy. Then, see the typical pattern of liver enzyme derangement is hepatocellular, and this correlates with the development of phase, obviously. Kikuchi Fujimoto is essentially a localized version of SLE in the lymph node. So you have these plasmacytoid dendritic cells that are producing relatively large amounts of type I interferon. So you can have leukopenia. It happens in around 25% of cases. And you can have atypical lymphocytes. Our patient did not have leukopenia, but as you can see, it doesn't go against Kikuchi. So I was thinking of Kikuchi Fujimoto in this patient. The odd thing was that I'm going to discuss in the next slide. That is the patient's demographic profile. Now, just to get it out, there, Kikuchi Fujimoto can have systemic manifestations, particularly CNS involvement in the form of ataxia and aseptic meningitis. Ataxia is relatively uncommon in SLE, and there can be GI involvement, and that can take any form. It is a variable presentation. And to complicate matters, this can Kikuchi Fujimoto can also progress to full-fledged SLE. So as you can see, it can cause clinical confusion. Now, comparing sarcoidosis, SLE, and Kikuchi Fujimoto in terms of the patient profile, uh, actually goes against this patient's clinical presentation. So let's see what happens. The patient profile of sarcoidosis is something that depends. It is more commonly seen in female patients than male patients, but barely. That is 57 is to 43. It's more common in African Americans, but obviously in India that is not a consideration. The SLE is significantly more likely in ladies with a 9 is to 1 ratio and can affect any racial. There's no racial prediction as per se, but yes, the severity of disease does vary depending on the racial patient. Gucci Fujimoto is also shows a female predominance like SLE, 4 is to 1. Um, However, it is much more common in Japanese population, at least there that may be due to a diagnostic selection bias. But the mean age of presentation is 40. The patient is slightly older than expected for Kikuchi, but yes, does fall within the range of described range of 2 to 75 years of presentation. Can can positive in sarcoma but is typically fine speckled and low titer positive. RF and APLA, RF may be positive in sarcoma, again is low titer positive. APLA is usually negative in sarcoidosis. In case of SLE, ANF-IFS is almost always positive. And RF may be positive in up to 10 to 25% of cases. APLA is positive in up to 40% of cases. All these three are negative in patients with Kikuchi Fujimoto. As you can see, our patient had negative findings. Now, uh, once you take the biopsy, as we just discussed, there can be confusion between Kikuchi Fujimoto and SLE list. And it is because of the presence of necrosis. So, what do we do about that? We can do C4D staining, as I've just alluded to previously. And necessarily, C4D staining is typically stronger because the necrosis is happening due to complement activation. Now, let's have a look at the histopathological findings in these entities. So, the first image is that of sarcoidosis. So, what you see here is actually the parotid cortex of the lymph node contains these discrete, you know, collections of histiocytes. How do I know these are histiocytes? Because these are very pale cells and they're very large. And they're forming these discrete collections, which are actually granulomata. The second case, we have some eosinophilic areas. Okay. And within those eosinophilic areas, we have this intensely basophilic deposits. This is what I was discussing previously. This is what we call karyorectic debris. And finally, we see another lymph node here, which has got a confluent eosinophilic area, which is actually necrosis, surrounding which we've got some areas of histiocyte infiltration and then some normal lymph node. And again, in higher fields, we find that there is infiltration with these histiocyte-like cells, okay, which actually happen to be plasmacyte dendritic cells. I've not shown the immunohistochemistry here. So that was Kikuchi Fujimoto. And how would I differentiate between them? By using your C4D staining. Again, the clinical context is important. So without the clinical context of Kikuchi Fujimoto, it would be difficult to diagnose Kikuchi Fujimoto. Um, and finally, we come to our acute infections. Now, in acute infections, obviously, we can have activation of multiple cell types. So as a result, there can be infiltration of the lymph node and expansion of multiple subdivisions of the lymph node. And this is why we call that pattern a mixed pattern. In mixed pattern, specifically in case of toxoplasmosis, there is a very characteristic histological triad. And that triad consists of one very prominently follicular hyperplasia, and that is to be expected, but also paracorticular expansion because of two things. One is the presence of B cells that are monocytic. So these are cells that look like monocytes or macrophages, but stain with B cell markers. And epithelioid histiocytes. Again, these are histiocytes that look like, you know, epithelial cells and have a squamosal shape. However, they have histiocytic markers, and but importantly, they don't form granuloma. Okay, they don't form granuloma. Okay. So finally, in a higher power field, this is the higher power field that is showing your monocytoid B cells. Now, for example, some of these cells are much larger than you would expect for B cells. B cells are small lymphocytes. This cell, for example, okay, it looks like an immunoblast, and we'll discuss the morphology of immunoblasts in subsequent discussions on this series. But suffice to say, this is a relatively large cell with a dense cytoplasm, a nucleus with a centrally located nucleus, and otherwise fine vesicle chromatin. So this is a monocytoid B cell, and monocytoid B cells look like monocytes but stain for B cell markers. And then we have epithelioid histiocytes. So on the bottom left of the slide, you find these large pale cells with relatively small nuclei, and those are what we call epithelioid cells. But they are must stain for histiocytic markers, so these are epithelioid histiocytes. So in this discussion, as of now, discussed. Uh, we've understood how different mechanisms of lymphadenopathy produce different patterns of lymph node tissue hyperplasia. We've discussed the follicular pattern and what we mean by follicular hyperplasia versus mantle zone hyperplasia versus progressive transformation of the germinal center, not the mantle zone, the germinal center. We've discussed the sinus pattern and we've discussed R group histiocytosis, although superficially. I'm standing for closing off. We've discussed the paracortical pattern when we've compared sarcoidosis, SLE, lymphadenitis, and Kikuchi Fujimoto in detail. We've discussed that mixed pattern happens with acute infections, and in particular, we've described the histomorphology of the toxoplasmosis and described the classic triad of toxoplasmosis. Now, I'll take a little bit more of your time and try to update the diagnostic framework for generalized lymphadenopathy and splenomegaly that I had come up with previously. So this is what we're going to do in the remainder of the discussion. So this was our general framework. So we had discussed that RBC phagocytosis and extramedullary hematopoiesis does not result in generalized lymphadenopathy because at no point during fetal development are lymph nodes a site for uh, RBC production, and even extramedullary hematopoiesis very rarely affects lymph nodes, and even if it does not affect lymph nodes in a generalized manner. So it's not generalized lymphadenopathy. However, lymphoid cell proliferation due to immune activation, whether it be due to an infection or not due to an infection, does result in generalized lymphadenopathy. Similarly, cellular or non-cellular infiltration of lymph nodes also can result in generalized lymphadenopathy. So, how can we update this now with this deeper understanding of the histological changes that happen? Let's see what we can do. So, yes, there is lymphoid proliferation, but what kind of lymphoid proliferation? So, off the half hand, I would say follicular hyperplasia is to be expected. But if there is significant type 1 interferon production, I would also expect, like in SLE or Kikuchi Fujimoto, paracortical hyperplasia. If there are granulomata that are formed, then I would also expect the paracortical regions to have granulomata. That would the archetype of this would be sarcoidosis. I would expect really nothing in case of increased IBC phagocytosis unless the primary pathology causing phagocytosis is infecting the spleen as well as the uh, lymph nodes. And then I would not really expect anything in case of extramedullary hematopoiesis. But in case of cellular infiltration, if it is infiltration by metastatic cells or histiocytes, remember they do not express CCR7, they do not express CXCR5, so they would have a sinus distribution. Fine, all that is fine. Now, what about splenomegaly? I have not talked about the spleen. I have not talked about the histopathology of the spleen. But why? But the reason for that is that clinically, the spleen, removing the spleen and looking at it under the microscope is prohibitively difficult in most clinical scenarios. So instead, what can I do? So one is look for a lymph node because that is the easiest thing to try to take out. So conditions in which there is lymphoid cell hyperplasia due to immune activation, regardless of whether it is due to an infection or not due to an infection, also have lymphadenopathy. It could have lymphadenopathy. You could sample that. Also, the spleen is drained by the portal vein, and portal hypertension could result in enlargement of the spleen. So you can rule that out by doing a portal ultrasound. We can also wake up the patient for extravascular hemolysis. Okay, and extravascular hemolysis would not cause lymphadenopathy. Again, unless the primary pathology itself is in through another mechanism causing lymphadenopathy. So we do these two things. We look for an alternate lymph node sample. We look for portal hypertension and any features of portal hypertension on imaging, and we rule out extravascular hemolysis in the correct clinical setting. Then what do we do? When all else fails, I consider a bone marrow biopsy. Why? Because in case of extramedullary hematopoiesis, the hematopoiesis is moved out of the spleen of the bone marrow for a reason. That reason can be found in bone marrow. So we'll do a bone marrow. Okay. Now, secondarily, if there is cellular or non-cellular infiltration, even if it is not affecting the spleen, it could affect the bone marrow. So bone marrow is much easier to access than the spleen, and therefore it would make sense to. So that is my updated framework for evaluation of generalized lymphadenopathy and splenomegaly. I hope at this point you are clear regarding the logic and reasoning behind it. Now, in subsequent discussions in this series, I'll be delving into the individual benign pathologies in the next discussion immediately after this in this series. And then I'll be talking about malignant disorders of B's lymphocyte origin, histiocytic origin that cause generalized lymphadenopathy. So I look forward to discussing this with you, and thank you for watching.